Namaste and greetings from the World Health Organization. My name is Chandra-Mouli and I lead the work on adolescent sexual and reproductive health and rights in WHO's headquarters. This module, I will introduce you to a global perspective on antenatal care, intrapartum care and postnatal care in adolescents. My segment will be followed by a colleague from WHO's Eastern Mediterranean Regional Office who will present a regional perspective on this subject. This slide presents definitions on antenatal care, intrapartum care and postnatal care. So antenatal care is care provided during pregnancy by skilled healthcare professionals to ensure the best health conditions for both baby and mother. Intrapartum care is care provided during childbirth, again by skilled healthcare professionals to ensure the best health conditions for both the mother and the baby. And postnatal care is care provided up to 6 weeks following childbirth, again by the same professionals with the same objectives. This is one of 2 slides which provide the rationale for investment in and attention to this area. It makes 2 points. The first point is that adolescent pregnancy is common. In this slide, you see the estimates for the number of pregnancies in the 15 to 19 years age group in the year 2016, as well as an estimate of pregnancies that occur in the under 16 age group, that means 10 to 14 plus 15. The drivers of early pregnancy and childbearing are context specific, and they include child marriage, they include lack of opportunities for education and employment, and values related to womanhood and motherhood. In many places, still in this day and age, the woman's primary role is childbearing and child rearing. The second point is that adverse maternal health outcomes among adolescents have major health and social consequences. Death, morbidity, and in addition, early childbearing leads to poor health outcomes in babies and children. This slide extends the discussion that we began in the previous slide, providing the rationale for the investment in this area. It makes 2 points. One is the interventions that are available for antenatal care, intrapartum care, and postnatal care are effective. They've been proven to work in research studies, they've been proven to work in large-scale programs. And so these interventions are available to reduce mortality, morbidity in mothers and in babies, and to ensure a quality and a positive pregnancy and delivery care experience. The second point is access to and provision of good quality services needs attention. As indicated in this slide, there are groups of adolescents who do not get the quality access to care, and even when they are in a facility, adolescents do not get all the elements, all the components of quality care that adult women do. Of course, this is not everywhere, but studies have shown that this is not an exceptional situation. This slide presents a global overview of the percentage of adolescent girls aged 15 to 19 who have received at least 4 antenatal care consultations between 2013 and 2018, and so clearly before the COVID-19 crisis. The global average is 56%. There are low rates in South Asia and Sub-Saharan Africa, as shown in this slide, and the rates in the Eastern Mediterranean region are somewhere in between, given the huge diversity of countries of the region. This slide provides an overview of the percentage of births among adolescent mothers aged 15 to 19 that are attended by a skilled health personnel, typically a doctor, a nurse, or a midwife. Again, data for 2013 to 2018. And what you see here is, of course, the rates are higher than for antenatal care, with a huge spread in different regions, with sub-Saharan Africa lagging behind, and the Middle East and North Africa um, far higher than the global average. So clearly there's work to be done, but this is much better than for antenatal care. This slide deals with the human rights obligations for provision of antenatal care, intrapartum care, and postnatal care. It makes 2 points. One is that upholding adolescents' rights in this area is linked to obligations of states to ensure universal access of interventions during, before, and after pregnancy to girls and women. The second point is that maternal health care that is provided should meet certain requirements as listed. In moving forward in this area, there are 2 points to consider. One is that pregnant adolescents, especially unmarried ones, often face barriers to accessing maternal health services, including antenatal care, intrapartum care, and postnatal care. Earlier in my presentation, I shared with you an overview of levels of access to antenatal care and skilled birth attendants. And you can see that although rates are higher for skilled birth attendants, there are still substantial proportions of adolescents who don't have access to skilled birth attendants, and coverage of antenatal care is much lower. The second point is that access is not enough on its own. It needs to meet certain levels of quality, and so health workers need to have the competency to provide care. They need to have the right attitudes and values, and in addition, they must be held accountable for delivering the services that they are meant to and in the right way. This slide lists a rich body of guidelines that WHO has produced in the area of maternal health care. The vast majority of these guidelines are not adolescent specific, but they are adolescent inclusive in that they include content that is relevant to adolescents. Increasingly, there is more and more attention to adolescents, both in terms of clinical considerations and in terms of interpersonal and social considerations. This slide contains a list of publications of WHO which are complementary to guidelines but do not meet the level of WHO's guidelines. In addition, there are some documents by other organizations. This entire body of literature is available, open access to all, and the organizers of the course are making these materials available to participants on request. In 2020, WHO worked with UNFPA to publish a technical brief titled Not on Pause, responding to the sexual and reproductive health needs of adolescents in the context of the COVID-19 crisis. In relation to the 2 previous modules on comprehensive sexuality education and the provision of contraceptive information and counseling services and the provision of contraception itself, I shared with you the recommendations of that document. In this slide, you see the recommendations on the provision of antenatal, intrapartum, and postpartum care. I'll not go through the points one by one, but they are about providing information to adolescents on where to seek care, on seeking counseling and screening support remotely, and when services are disrupted, to have a strategy to ensure that maternal health services can be accessed by all segments of the population, and especially within that, those most vulnerable, including adolescents. This little cartoon shows this exchange between a health worker and a young couple who are getting ready for the arrival of their baby. And you can see the discussion on what do you do in case access to services is restricted, either because of closures of health facilities or because of restrictions in movement. In the module on the provision of contraceptive information, counseling, and services, I shared with you the findings of WHO's National Pulse Survey on the continuity of essential health services during the pandemic, and paid particular attention to family planning and contraception. In this slide, you can see how antenatal delivery and postnatal care services have been affected, and these, of course, are part of a whole package of services that have been affected, but effects of the disruption of maternal health services are significant, as you will see in the next slide. In the previous slide, I shared with you data on disruption of services in general and maternal health services particularly. And the effects of that are evident from this systematic review and meta-analysis. This review published last year showed a significant increase in stillbirths and maternal deaths and postnatal depression scores. So clearly, when maternal health services are disrupted, there are tragic consequences at the individual level and at the society. My last slide in the global segment of this presentation is on maternal health in the humanitarian context situations. 2/3 of preventable maternal deaths and 45% of newborn deaths take place in countries affected by recent conflict, natural disaster, or both. What happens here is that there's a breakdown of health systems, there's a breakdown of families' abilities to cope, and so there are huge problems as a result. This is clearly something that needs to be on our radar screen and on our agendas for action. This is true globally, but this is of particular relevance to the Eastern Mediterranean region, and my colleague will discuss that in the subsequent section of the presentation.
Hello everyone, I'm Dr. Hiba Hussein. I'm working for WHO Sudan Country Office as RMSHA officer. I'm so glad to be facilitating this session on antenatal, intrapartum, postnatal care for adolescents from a regional perspective. It's so important to start by having some information and providing some information about the maternal mortality ratio among adolescents in the different regions of WHO, as well as the maternal mortality ratio and how it is differs from country to country. So we need to know that EMRO has the second highest maternal mortality ratio globally, and it comes after Afro region. And among the 22 countries in EMRO, Somalia has the highest maternal mortality ratio, which is 829. This is per 100,000 live births, which is also followed by Afghanistan as the next country with the highest maternal mortality ratio, with total of 638. This is per 100,000 live births. By having said this, it's so important to know how maternal conditions are contributing to maternal mortality and maternal deaths among adolescents. And from this slide, we see that there are some countries where maternal conditions considered as number one cause of deaths, like Somalia and Yemen, while some countries, maternal conditions are considered to be the second cause of death, contributing to maternal mortalities among adolescents. And also some countries have the maternal conditions as number 3 cause of death. However, there are some countries where maternal conditions are not among the top 5 causes and dalis of deaths among adolescents. So the investment and improvement of maternal conditions has direct contribution to reduction of maternal mortality ratio among adolescents. So we can see from this slide the difference between the countries in terms of the coverage by some key indicators that can measure the maternal conditions and maternal health for adolescents. So for instance, taking 4 or more than 4 antenatal care visits in Jordan, we see that the percentage is 93.2, while in Afghanistan it's just 16%. Another key indicators that measures the maternal health and contribute to improvement of maternal health is the skilled birth attendance. And we see also from this slide that Jordan has 99.1 coverage with assistant or skilled birth attendance, while we see that Yemen has just 50.9 and Afghanistan has 50.1. Another key indicator, which is the place of delivery, whether it takes place at home or facility, we can see that there is a huge difference between the different countries. The percentage of the deliveries at home in Jordan is just 2.2, while in some countries it reaches 50.4 and more, for instance, in Afghanistan, Yemen, and Sudan as well. And if we get back to the previous slide, we see that the same countries with this high coverage of these indicators that measure ANC, the intrapartum care, postpartum care, the same countries that the high coverage of these indicators has also good indicators in terms of maternal mortality ratio and in terms of the conditions that contribute to maternal deaths among adolescents. Another key indicator is the presence of legal and policy support for maternal health services. Out of 16 surveyed countries, 15 countries have national policies on antenatal and postnatal care for mother and newborn. 15 out of 16 countries have the policy regarding the right of every woman to access skilled birth attendance. And we see that Somalia is the only one country that doesn't have policy for the provision of health services at country level. Maternal health services are also being affected by too many different factors and determinants, including some social determinants and other contextual, political, and some key factors. An important study conducted in Afghanistan in 2015 aimed to assess the current status of utilization of maternal health care in Afghanistan and the factors associated with it. This study has very interesting results in terms of how different factors affecting maternal health care. The key indicators measured in this study included the ANC among adolescents from 15 to 19, which was 18.1, skilled birth attendance, which is 54.2%, and the cesarean section, which is 4%. The result has shown that how education, which was taken as one of the key factors that affects the maternal health service, how education of the girl and their husbands, the wealth, access to transportation, urbanity, and autonomy are powerful factors affecting maternal health care. And the autonomy was defined as ability to decide alone for the women or jointly with their husbands about how to spend the husband's earnings. So this factor is affecting the education level, and these other factors are contributing and affecting maternal health care. For instance, compared to women with no formal education, women with the highest education level were almost 4 times more likely to receive ANC, 13 times more likely to deliver with the skilled birth attendants, and more than 2 times more likely to deliver by C-section. And compared to poorest women, the richest were 3 times more likely to receive more ANC, 11 times more likely to deliver with a skilled birth attendants, and 2 times more likely to deliver by C-section. Women with the decision-making authority on how to spend their husband's earning were 2 times more likely to have 4 or more ANC visits, 1.3 times more likely to deliver by a skilled birth attendants, and 1.4 times to deliver through C-section than women who have no such autonomy or authority to decide on their husband's earning. Maternal health care, including ANC, intrapartum care, postnatal care, is also being affected by different emergencies, including disease outbreaks and humanitarian emergencies. Taking COVID-19 as one of the emergencies and outbreaks that affect the maternal health care, we see from this slide that in some countries there are some studies conducted to assess and measure the disruption of the health service, mainly maternal health service, to see how COVID has affected the maternal health and the provision of essential maternal health service, including antenatal care, postnatal care, and intrapartum care. So in Sudan, for instance, the percentage of women delivered by skilled birth attendants, it varies from 2019 to 2020. So we see there is a reduction, huge reduction in this percentage in 2020 due to COVID-19. Also in the PNC coverage, we see this reduction due to COVID-19. In Yemen also, the ANC coverage has been affected, and there was a reduction in the coverage by the ANC due to COVID, and in Pakistan as well. The number of the births and deliveries at facility level also has shown some reduction to COVID-19. So by having said this, we can say that emergencies are also including disease outbreaks are also contributing to maternal or affecting maternal health care and contributing to reduction of coverage of by the services and maternal health services. Maternal health and adolescent health are also being affected by different factors in humanitarian setting. A study conducted in Syria and aimed to assess intervention coverage indicators and implementation challenges inside Syria during conflict has shown that there are too many factors affecting maternal health in humanitarian setting. These factors include lack of prioritization of adolescent health service and the different competing agendas and priorities in these humanitarian settings. Insecurity is also a key factor that affects adolescent and maternal health, which restrict and limited the movement due to insecurity and attacks of health facilities, which prevented also the health care seeking as well. Shortage of specialized health care provider is also affecting the maternal health and adolescent health in humanitarian setting. However, in Syria case, they have adopted task shifting, which was done by training of general practitioners, surgeons, nurses and midwives to fill the gap in specialized health care workers, mainly obstetricians and gynecologists. So they have trained cadres, including midwives and nurses, to provide these obs-and-gynae services. Procurement restrictions also one of the key factors affecting provision and availability of maternal adolescent health in humanitarian setting. There was another factors identified by this study in Syria, which was the problem with the MISP, the Minimum Essential Service Package, and other life-saving interventions. However, this intervention was categorized and prioritized. But in Syria's case, it was resisted by the Syrians at the first because there was a pattern of bypassing primary service that existed before the war. So there was a resistance because they were used to pass the PHC where the MISP is mainly being provided during the emergency. As we have seen that there are too many challenges facing adolescent health and maternal health in this region, there were some initiatives implemented in different countries to improve adolescent health. One of these initiatives is an initiative implemented in Pakistan and aiming at advocating for improved maternal newborn health and sexual reproductive health policy and practice for adolescent girls and young mothers. The initiative was implemented over 14 months. It was a 14-month project and implemented in a partnership with Family Planning Association in Pakistan. The main aim was to increase awareness regarding the specific reproductive and sexual health needs of adolescents, girls, and young mothers, and to advocate for their inclusion in provincial health policies in 4 provinces in Pakistan. The main outcomes from these initiatives were a robust advocacy strategy was designed, advocacy campaign was planned for federal and provincial level, various key stakeholders of maternal neonatal health and sexual reproductive health were willing to accept their responsibilities for ensuring supportive environment for youth. Another key initiative was implemented in Sudan from October 2011 to December 2012, and it was a community-based intervention project implemented in Kassala town in eastern part of Sudan and the rural Kassala localities covering the catchment communities of 19 primary health care units. The main objective was mainly to strengthen the primary health care and the community mobilization to contribute to improved health and well-being of mothers, newborns, and their families. And the main outcomes out of this initiative were the capacities of the PHC was enhanced with training of staff and providing supplies, the introduction of the referral fund to cover cost of the antenatal and other maternity care service, community mobilizations through establishment of network and channels to reach the audience at their residential areas through women as change agents, and continuity of supplies of family planning methods. As there were some initiatives implemented in different countries to improve adolescent health, there are still some regional opportunities to improve adolescent health which are fully aligned with the global initiatives and guidance. These opportunities include Global Strategy for Women, Children and Adolescents, which is an opportunity for the countries to integrate adolescent sexual reproductive health interventions to achieve the global targets of reducing maternal mortality ratio to less than 70 per 100,000 live births, contributing to SDG 3. The plan of this strategy is to strengthen the healthcare delivery system, improve skills of the health workers on early detection and management of complications in pregnancy and delivery. Another regional opportunity is the adolescent health in all policies. It is a strategy to consider the implication of decision on adolescent health, avoid harmful effects, and seek synergies. It facilitates the formulation of adolescent responsive public policies in the sectors other than health. It also encourages different sectors to include adolescents in their policies, strategies, and plans, and to improve their information system to provide the needed information to measure adolescent related indicators. Another opportunity is the Vision 2023 Health for All by All, mainly universal health coverage under the general program of work 13 for WHO. It gives and encourages the inclusion of adolescent sexual reproductive health evidence-based intervention in the regional priority benefit package and encourages different countries to prioritize adolescent health interventions in different settings, developmental, emergency settings, and to prioritize the adolescent health to be part of their benefit package and then to be part of the regional benefit package and support.